I have two sections for my presentation: tools for analysis to begin with, a step back, and then strategy for action. Like many other speakers on the panel have ended with action. Way back in 1970, Samir Amin, in this book, Accumulation on a World Scale, talked about the world capitalist system, and he contrasted that concept with imperialism. So I wanted to tackle that given our topic today. Amin's critique of Lenin's book, Imperialism, Highest Stage of Capitalism, as well as Baran and Sweezy's book, Monopoly Capital, trace the formation of monopoly capital in so-called developed countries. So Amin critiqued that there was no tracing of connections between so-called developed countries, we also call that the core of the world system, and so-called underdeveloped countries, also called the periphery. Amin also said that Argiri Emanuel's concept of unequal exchange was but one form of transfer happening from the periphery to the core. Many other forms to be thought about. So Amin argued that what is needed is a general theory of capitalist formations. This means to understand successive forms of primitive accumulation in relation to transformations in the core of the system. All of this transfer is capitalist in Amin's view, if we look from the 15th century, late 15th century, so arrival of the Europeans in various other continents of the world. This is very different from Rosa Luxemburg or other Marxist formulations of the periphery or the South as pre-capitalist. When we take that approach that Amin is recommending, we can put the question, why is it that Africa does not have a COVID vaccine of its own today? Fast forward to the answer. The African Union, which is the gathering of all African governments, decided to pool their resources to borrow $2 billion from the Africa Export-Import Bank instead of investing in clinical trials for a vaccine that came into being in 2020 through the African Center of Excellence for Genomics and Infectious Diseases. There was a vaccine that could have been trialed within Africa for a cost of under 350 million, as low as $7 million. Instead, our governments chose to borrow $2 billion from this supranational public-private bank. Please ask me about that if you want to know more. Come 1974, Emanuel Wallerstein took up Amin's idea of the world system, and he presented this book, The Modern World System, arguing that imperialism, monopoly, and unequal exchange were all phenomenon that began from the 16th century and continued into the present. About 20 years later, Giovanni Arrighi refined many of Wallerstein's notions in the long 20th century. He talked about cycles of hegemony. And in each of these cycles, a material expansion followed by a financial expansion. Arrighi also goes back to the 16th century and comes forward. Quick point on hegemony. Hegemony is that core of rich countries led by one of them. And a hegemony consists of political elements, economic, military, even cultural, as we can see particularly in the US cycle. I discuss all of this high theory in an upcoming article, which you can see here. It will be coming out in August in this journal. Let's hone in a little bit on US hegemony in particular. So US hegemony extends from everything from French fries to intensive care units as our notion of healthcare, to the study of politics, which we study independently of economics and history. So all of this mono analysis and disciplines that are very separate from one another. The commodification of healthcare is an aspect of US hegemony. And I want to look at that through the lens of medical technology, devices, diagnostics, and medical supplies. This is a monopoly structure of production starting in the early 20th century. I trace that in my book. By 1999, here is a way to concretize what does monopoly mean. 12% of companies producing these medical devices, testing machines, medical supplies, dominated the US industry. By 2017, 20 companies controlled 55% of the global market, and 12 out of those 20 were US American companies. I trace this history in my book, as I mentioned. Let me illustrate all of this through COVID-19. These are companies producing some of the key medical technology needed to crush this pandemic. Becton Dickinson and Danaher, two US companies, produce PCR tests, which we all have heard about by now, I hope. This is the gold standard test for the for the coronavirus. It was approved by the WHO way in the beginning. Becton Dickinson and Danaher produce the testing machines and the reagents or chemicals needed to read the tests. In the very beginning of the pandemic, in about February 2020, the WHO released a recipe online for testing reagents. Okay, this was before Danaher had even come up with a test for the novel coronavirus. When Danaher's test came out, it was only compatible with Danaher reagents and Danaher machines. Becton Dickinson did the same thing. So though there was that free recipe out there, they made sure that their tests would not work with the free recipe reagent. This had huge consequences for many countries, particularly in the South. South Africa and Peru, for example, suffered shortages of reagents. They had invested in testing, they had invested in tracing, and even in the machines, but they didn't have the chemicals to read the tests. Why is that important? Because in the first wave of the pandemic, which is when we should have really crushed the pandemic so that we wouldn't have to deal with all the variants that we hear so much about today. In that first phase, without the reagents, you can't read the tests quickly enough to do the tracing and to stop the spread of the virus. There are similar stories around 3M. around Medtronic, and you can read about those. We, of course, also know a similar story about the COVID vaccines. The key points to take here: underproduction is at the root of both national and global shortages of medical technology, including vaccines. When we hear about vaccine nationalism, we tend to forget about this monopoly dynamic of underproduction. That is the control of the supply to keep prices up. The single payer healthcare system in Canada does nothing to challenge this. Obamacare, nothing to challenge it. And of course, Biden's $200 billion committed toward affordable care premiums doesn't touch this monopoly structure in the least. So the story of inequality when it comes to fighting COVID-19 is much bigger than Biden or Merkel or any of our governments, who we tend to blame, right, for everything at this time. Let's go to action. Why action? Because we are seeing mass death happening now. We've got basically double the deaths globally caused by COVID and indirectly and directly. In some countries like South Africa, it's 4 times more. We are told that the waves are inevitable. More and more waves will happen. And you can see the waves there. We had one globally in August, we had another in December, and we're seeing one now, and the current one is spiking up higher than all the rest. What do we do about this? Zero COVID is the strategy that I'm advocating for. And in the longer term, decommodifying healthcare. What is zero COVID? Quickly. Zero COVID is a strategy driven by neighborhoods. So everything from education about COVID to managing the spread of COVID using rapid tests, not the PCR tests that I just talked about. Rapid tests are cheaper and you get the results more quickly. To tracing, so who have the people that are testing positive been with lately, and imposing lockdowns neighborhood to neighborhood. At the same time, we need support of states to neighborhoods, not via NGOs, but directly to neighborhoods to make all of this stuff happen. Make sure people have income so they don't have to go to work when they're sick. Make sure people have food. Cook the food collectively and safely and deliver it to people. All of this basically empowers people to understand the pandemic and to feel like they can stop it. As you create more and more COVID-free neighborhoods, then you can have movement of people, you can have exchange. This is a way also to make people active rather than passive in fighting the pandemic, to take the militarization out and return the focus to care, which is what we need for any health issue. I argue that all of this will lay the seeds for a movement to decommodify healthcare. Both COVID and the decommodification of healthcare are issues that bring us together globally in a way that other health issues have not. Why? Because we're all living COVID in the same moment. The action has to be at the very grassroots, but concurrently around the world. And if we get corporations out of the production of drugs, out of the production of all other medical technology, as well as food, everything related to health, if we put communities into control of healthcare delivery, if we put healthcare workers, scientists, all of the other workers involved, as well as patients, in designing healthcare, well, then we have taken back a lot from the hegemony of commodified healthcare. I have written about all of this in this article that you see below in English, and Regions Refocus has graciously translated the whole thing into Spanish. So I encourage you to read that, and I look forward to your questions. Thanks very much.